Well, we're near the end of our 2 amazing days for this event, but in reality, it's only the beginning for the BigMedilytics program. And I am pleased to welcome on stage, right here, Professor Klemens Dr. Budde, the head of the Department of Nephrology and Medical Intensive Care at Charité, Professor Antoinette Debont, the Dean of Tilburg School of Social and Behavior Sciences, Professor Ricard Martínez, the Director of the Chair for Privacy and Digital Transformation at the University of València, and Dr. Hans Hofstraat, Vice President and Senior Fellow, Program Manager at Philips Chief Technology Office. Welcome. We have another distinguished panel today, and I know we've seen your faces well over the past 2 days, and the discussions have been very intense and frankly a lot of detail. But what I really want to focus in on and nail down in this last session is, how do we take this forward? What are we going to do tomorrow? Now, we've heard all the teams from the pilots talk about the challenges that they've had to get to this point. We've heard the background, the blueprint, the pilots, but let's put that aside now. It's now 2021, September 13th, let's call it September 14th for the sake of argument. What do we need to do as a system or individuals to move forward? So I'm going to start with a difficult question, and I know there are lots of obstacles and challenges. Maybe we'll call them opportunities, and I know there's a lot, but let's just start with one. So the first one that comes to your mind, what do we need to do differently tomorrow? And I'll start with you.
Okay, I think we need a common legal environment for Europe. What we learned is that we need to develop platforms. Alexander told us about federated processing as a solution.
Yeah.
If we have to deal with anonymity and we have to process data in local premises, we need to define these federated strategies. This is due to the legal compliance on GDPR. Okay, this is a solution, and this is a wonderful solution.
Yeah.
We could federate, we could process data in local premises, we could share inferences. Okay, all of that is good.
Okay.
But I think we need to think on European platforms.
Yeah.
We have to think on sharing knowledge. We have to think on our transnational and transatlantic cooperation.
Yeah.
Because remember, probably we feel uncomfortable with United States laws, but they are an Occidental democracy who are researching like us. And in front of us is China. It's a question about competitiveness of democracies between places for research where there are no laws or where there are different laws.
Right, right.
In that sense, we have to think on Europe to process data. And this is not regards to the infringement, this is not regards to the human rights of patients. This regards about how to do that commonly. And that's my main concern, because I need to have to think on that, not only like jurists.
Yeah.
I don't want to be a privacy championship in this way,
Right.
crying in every case. No. I want to be the privacy championship to promote solutions to help people. And we felt a long time of individualism. Remember COVID?
Yeah.
See in our countries, we are dealing with COVID, telephone people. We could locate people in real time, we could trace people in 1 minute, and we decide to call all of them person by person.
Right, right.
This is really incredible.
Federated system.
Yeah, this is my main concern. How to deal ourselves with a common laws, with a common rules, protecting people, granting human rights, but in the same way, in the same direction.
Wow, you started the triggering conversation already. So I'll let you follow up.
So I would think that from the very global perspective, I think we have seen over the last 2 days fantastic pilots, and I think we should move the momentum we got from these pilots and bring it into clinical routine, scale it up. I think this is what is for the concrete for us is the next step. Yeah. Take this momentum from working together with different people and then bring it to the patient and scale it up, bring it to other hospitals and so on. I think this is from my point of view, or my message here, this would be the next step moving ahead.
Let me challenge you on that. Who should do that? Is that the CIO, the CMOs? Is it the policymakers? Is it industry? Like, who is going to do that?
I think we have to do it. So we made the experience, we have the momentum, and I think what we learned over the last years, I think this is also crucial, and this is our knowledge, and we have to disseminate it and bring this forward, and I think this is the next step. Of course, there is a lot of obstacles in our hospitals, in other hospitals. People are hiding behind the GDPR. This is the best way. Oh, this is not GDPR, so we cannot do it.
Yeah.
We have to leave it. We have to call. We have to use a fax machine. Yeah, which a fax machine is not GDPR at all.
Fax machine.
But this is, I think, the way people trying to hide, and we have to overcome this. Of course, GDPR is a basis for this, and I think this also differentiates us from US and China. Yeah. Because they don't have it. Yeah, and we have this. The GDPR, we have this, and we can use it, and I think this is our chance here for Europe to move ahead.
So, please, I was going to ask you directly. That's a behavior issue.
Oh yes, but I want to follow up on your question about who should do what.
Yeah.
I think it's a very relevant question.
Please.
So you answered what should the policymakers do, and you said no, we should do. I think that's a key message, because what I learned at BigMedilytics, that we are now at the age of learning what AI can bring in healthcare. And I studied the first electronic health record in 1990. Okay. So really long ago. And there I saw the same pattern. We had one electronic record for one ward in one hospital. And now we have an electronic record for the whole system.
Right.
And what we learned in that 20 years was to understand what can we do with an electronic health record, care pathways, restructuring care. So I think it's now too early to bring the policymakers and say big plans. No, we have to learn, and based on that, to think about how can we dream about organizing healthcare differently. And I saw very nice ideas. Not only decision support, that's doing the same with the new technology, but also thinking about personal healthcare.
Yeah.
Or putting the patient in the driving seat of the care delivery. So these small things we saw, the restructuring of care, that's what we need to dream of. And what I learned from you by studying you with my team, you are good dreamers. You are really good dreamers. And that is necessary to overcome that long stretch. So I'm thinking not in 1 year, I'm thinking in 20 years.
Okay.
And then you need to dream about a new healthcare system and try that on, by pilot, by pilot, by pilot, and then it will pile up into a huge new healthcare system.
Hans, before I trick you, you tricked me earlier, and I was thinking about the question you had, because what do we say to those people who say, look, I have enough on my plate already, I'm already in many transformation programs, I'm dealing with new IT systems, new technologies, and at the same time, you know, we're here to treat patients, right? I mean, they're the most important, that's why we exist. But let me ask you then, so I'll ask you all a question, what would you say to the person who says, it's just too complicated to take this step now? What can we do? What carrot can we throw to those people who rightly so say, look, it's just too much and I have too much on my plate? I don't know.
I think we have to adopt the patient perspective.
Good.
If you provide a patient with a practical tool, okay, I have in my smartphone a QR lector that provides me, see please, how much I choose in a restaurant. If an ancient people has a smartphone telling him, okay, this is the time for your medicine, here you have the photo. If you provide people with useful solutions, they adopt it immediately.
Right.
Because people want to feel well, want to improve his or her health. That's our main approach to that. And we need telemedicine in remote areas. We need participations. We need predictive and population medicine. We have a new approach. What I understood from these guys is that they are providing us tools for primary care uses.
Right.
This not regards only about fundamental research.
Sure.
They are thinking in what we can implement to improve healthcare tomorrow.
Right.
We prefer to call you because you will have a problem in the next 2 months. And it means savings for healthcare systems.
Yeah.
It means quality for patients. And to do that, our legislators, our politicians, our governments have to apply this kind of privacy by design, in this case, legal by design.
Yeah.
And in privacy by design, we have to see reality first. Then this is not about your thoughts, your main ideas, what we will read in newspapers. No, no. This is about persons. This is about researchers. This is about hospitals. Please call them, hear or listening to them, know their needs, and then please regulate. But in this order.
May I add that?
Absolutely.
So maybe I would phrase the question differently, because what we saw in this project, it were not the individuals that had to step, that makes the big change, although it's a step-by-step approach. But when COVID hit, then you and your organization suddenly need monitoring online or at remote monitoring. So, and that's also what we saw in healthcare, when there is a external development, more chronic disease patients that we cannot handle in the same way. That's the moment when we change. And I think for people that say, I have enough on my plate, I say, please do. Please take care of your patients. Please do. Right. That's your role. And we appreciate it. But we will be prepared. And the moment there is a break and we cannot do it in the way you do it, then we hope we are ready for you.
Let me say, this is not secret. This is not private. This should be inconvenient. 1 month ago, I have been examined by your DPO in other project to provide her certainty, security, and so on. Oh, it's okay. But what I'm feeling in these cases is that, okay, we are preventing the infringement on law. We are considering the risk for the hospital. But we are not thinking on researchers, patients, and so on. We have to change that.
So Hans, I know you've been chomping at the bit. I've cut you off, so please, what's your thoughts on this?
Well, I think we need to think in 3 levels. First of all, I think it's the enablers. I think you touched upon that as well. The enablers in terms of getting the access to the data. Without data, we cannot do anything. Without data, we cannot provide digital solutions. And so that I think is a condition that needs to be in place, and there's some pieces of regulation about privacy and legal. Technology, however, technology in principle is there. I remind you of Jeroen Tass's intervention. He started with finance, now everybody is using digital financial tools. The same can be done with healthcare. But that's, I would say, a basic condition. On top of that, there is education and trust. And so there's education and trust of the professionals in the hospitals, in the healthcare system, but it's also about the patients. And I was also triggered by the intervention by Professor Chomien on the first day, where actually she mentioned that patients are very ready to accept digital tools and information when they can help them. Actually, I was in a discussion earlier in Luxembourg, also on big data, and there were people in the audience with rare diseases, and they said, actually somebody was attacking me a little bit on digital solutions, but somebody from the audience, a patient with a rare disease, said, we have set up on Facebook a solution to share data, and all of us patients are happily sharing the data because we are convinced we get a benefit. And so actually, maybe at some point, the patients will run ahead of us and convince the authorities to regulate these things in an appropriate way. And so that is the second level. However, the third level, which is maybe the most tough to address, is the level of healthcare transformation. And there I think your 20 years or 2 decades, I hope it can be faster, and maybe COVID there is helping, because the care that we are used to provide, we cannot continue to provide. Healthcare is moving outside of the hospital, but then in looking at some point, healthcare also needs to be paid for. And then you also have to have a broader perspective of where money is spent. Is it spent in the hospital, outside of the hospital? How is the distribution of the money organized? And there, I think that is maybe a major challenge where the COVID crisis can help us. And I think those are the 3 levels that all of them are complex. But I think, and of course I have to be a little bit careful here, working for a company that provides healthcare technologies, but I think that is probably not the most complex of the challenges we are ahead of us. I think some people from Erasmus University about a decade ago published about social innovation, and they studied how do we innovate and what are the, I would say, the crucial factors there. And about 20%, if I recall well, was related to technology, but 80% was related to social innovation, everything else. And that, I think, is the added value of the BigMedilytics project, because with all the stakeholders on board, yeah, we really have been able, or I should maybe say you have been able, because I was a little bit remote, have been able to identify the needs, the opportunities and the challenges to make progress. And I think that is yeah, to be applauded in this project.
May I add, because that's one of the lines I really want to stress. What normally do is we develop technology and then think about the business.
Yeah.
So, and then we call it implementation or scaling.
Yeah.
And that's the wrong phrasing. So you need to think about how we want to organize healthcare and how we want, what kind of roles professionals and patients have. And you do it from the start, because the social development take as long as the technology. So my dream, and we started in this project with it, that we develop it parallel. That the social development and the technical development goes parallel. Yeah. And that's hard, because you don't know, there are different paces and different ideas, but that's I think the main lessons. So think about the healthcare structure, think about the role of patient doctor from the start when you develop the technology. That's, I think, what I hope for the people that leave this room and I want to go further, think about that.
Yeah. But I think one important aspect with this regard is, and this is, there's no lunch for free, and so someone has to pay for it, number one. And the second one is that many people are reluctant to move ahead because they experienced over the last 20 years so many bad software solutions. Yeah. And they are really fed up by poor software performance. It always breaks down. It's not really good. The icons are this small somewhere, and nobody knows what it means, and so on. I think this is also we have to keep in our mind. And for this, again, the BigMedilytics was a lighthouse project, and I think the pilots are the lighthouses, and they shine a long way. And I think this is also maybe true for, and that we have providing good software solutions or good ways how it works. Yeah, and maybe for some patients or some doctors are not still resistant or hesitant, or the hospital administration is resistant to spend money. Yeah, that's also a very common feature nowadays. But still, we have to overturn this, and we have to show, okay, it works. It has been working, and maybe BigMedilytics shines the way for other people to say, okay, it is working and it is possible. Yeah.
Let me ask from my ignorance, my technical ignorance. I think you described a virtuous circle of innovation that must take into account social needs. But times change. Now we have data. And we have data analytics. Then if you need to think in innovation and we need to think in profit, we have in addition data analytics to identify new needs, social thinking, and so on. we are talking during all of our project about that.
But I disagree here.
Why not?
Because two things, I think. What we saw in many of your projects, and you can elaborate on that, is that when the physician has this
Let
data...
me say that I'm not thinking in healthcare records. I'm thinking in socioeconomic data, in other data sets regarding territorial breaches, connectivity breaches, energy needs from people. I'm thinking in society as a whole. In future, when we will research on healthcare, we probably need a lot of different data sets, not only healthcare data sets.
Yeah.
Okay, you confront me with my traditional perspective. Okay, done, deal.
But nevertheless, I think healthcare transformation works only if you bring together those people who have to work with it, the society and all the stakeholders. And this, I think, which is also one lesson learned, is that we need to work together and build teams. So software developers who are alone developing software will never make it. Also, as a physician, I cannot develop software, so I'm also not going to make it. I have to work together with people who are driving this process, and I think it's kind of, we need several people working together to drive this process. It's and just to say I will do the solution, no, it has to be adopted by the physicians in the workflow whatsoever, and they have to trust it. So there are many issues to discuss and to find out.
Yeah. The user interface, I think, is extremely important, and that, I think, is an added value of the project, where companies are working together with the clinicians, to the users and the end users, because in the end also the patient or the person needs to benefit, and that can only happen when there's rapid testing of everything that's being developed, and the user interface is a key element in that.
The wording is here relevant. I'm a sociologist. So the wording of resistance, I would be hesitant to talk about resistance, because you know, we don't know how this technology works in practice. We have an idea, we bring it into practice, people do new things with it. So I think it's that, so they develop that. So, and if people say, wait and see what we can do, I think we should take it carefully. And resistance has a negative connotation. So I never talk about resistance. I'm interested and curious what people think about technology. And the other is about adaptation. I think that's not also the way it works. It's like what you do in your work, you have an idea, you make a technology, you use it in healthcare, and then you start to understand, oh, if this is possible, then that is possible, and then we can do this and that. So it's this learning. So I would use the word, are we willing to learn together?
So we have, you had mentioned enablers, you had talked about a federated system, and you talked about the parallel tracks of the social. But I feel unfulfilled still.
Yes.
So I'm going to trigger you again. You know, we're seeing, so within this project there were a number of pilots. There were a number of individuals, there were a number of organizations that came together for those. So when we talk about a federated system, in a way we're thinking about how can we get all of the pieces of these systems working together, or at least going in the same direction. Maybe that would be at least a good ambition. So that means we have clinicians, patients, policymakers. We have the enterprises, the hospital managements, the owners of the hospitals. We have then the private industry feeding in solutions or working together in solutions. But I would ask you the question, how do we get to a, rather than going silo by silo, product by product, policy by policy, is there a way that we can really leapfrog this? Or is it just going to take time and learning? I know it's a tough question.
Yeah, absolutely.
Tough question.
That's for you.
It's for you.
That's for you.
There are many studies about whether healthcare systems change.
Yeah.
And it depends on the context. Especially the Dutch healthcare context never changed quickly. We are the slowest, but we are innovative, but slow. Okay. So that's typical, and many studies say that. If you go, for example, to England, there's a much quicker way to change, and you also see it in their development of data. The problem with that is, if there's a new politician, a new idea, then what you build up is gone again. So the idea is whether a radical change is better. I don't think that is the clue.
Wow.
So I would say, and we have many studies about that, it depends on the context. And in the Netherlands, we are innovative but slow. In England, they have more political system where there are more changes possible, but there's a risk that it changes back. So we need to take that into account and then try it out in the different settings and learn about it. So, and we know there will be big changes, but it's never from the system itself. It's external shocks that makes us to make that change, and we need to be prepared for that. So I don't think we can make that change, but we need to be prepared so that when this change is there, we know what to do, we can guide people, and we have things available. And that's exactly what we did in the Netherlands with the healthcare system. We prepared for a private system, a market system, for 20 years. And when it was possible, we were ready.
Wow, that was an incredibly good answer. I don't even know how to answer that answer. That was pretty good. Any thoughts from the others on that? Or other perspectives on my question?
The COVID crisis made it quite obvious that we need, or at least for Germany, it really was an enabler to start to make this kind of, okay, now we have to do something, there's something wrong. Now all of a sudden digital solutions were kind of en vogue, everybody was talking about, and nobody had an idea how it works. Yeah. And many ideas are kind of pushing around and dead ends or whatever. So I think with our project or with BigMedilytics project, we could say, okay, this is kind of templates or so. This is how it works. We have some experience. Yeah. We have built some GDPR compliant things. We don't have to import something from China or whatever. Yeah. So this is, I think, and GDPR is possible in Germany and so on. I think this is kind of was a, I think the COVID crisis will be seen as a turning point for digitalization in healthcare, at least in Germany.
Yeah. I think we have to change approach. Let me give you an example on COVID-19 crisis. All of you know the well-known mobile application called Radar COVID. It's an anonymous application where they implemented different layers of privacy. You use an absolutely anonymous number and you declare voluntarily your positive and so on. It takes us more or less 6 months to be developed. What public doesn't know is if we process data of location or additional data from a patient of COVID, it goes to a software of a hospital where they applied security measures, where all of uses are absolutely traceable. And if anybody does anything wrong, it's a serious crime. Then the data processed due to COVID purposes is absolutely protected, is securized, and there are criminal infringement if you do something wrong with that.
Right.
And then why do we need radar COVID application? Because law enforcement bodies don't access to this data. They will be used only for healthcare and public health purposes. And then what about changing mind of people, changing mind of newspaper, changing mind of our society about that? Because we are processing data for common good with all of protections, with all of security. What is the problem, please?
Right. Why is there not more press about the value of the GDPR, which I mentioned from the European Supervisory Board? I'm going to, unless you want to directly respond, I'm going to take us in a completely different direction I just thought of, so bear with me. It might come out a little odd, but it appears to me, because you talked about mindset change, that there's the one side which is we need to get the data, we need to have these tools to be able to process data, and then we need to have visualizations designed to make sure that the data is being seen. But really, that's a back-end issue. The core thing that we've heard over the past 2 days is the value of that data in making a change. And just one example out of all the pilots of 12, asset management today, getting real-time knowledge about what assets are being used in order to make new purchasing plans, for instance, or whether or not they've purchased the right thing is one thing. So I would ask you then, how do we make a mindset change to those people who are able to transform care pathways, transform operational efficiency, transform payment models, reimbursement models? How do we do that?
I think the only way to do that is by showing the benefits. In some cases, it's actually easier than in others, I have to say. So we, of course, we're very much involved in the prostate cancer application, and in order to measure any impact, for instance, on survival in prostate cancer, you have to wait a long time. Yeah. However, in the asset management or improving efficiency, in stroke, the cycle on analyzing the outcomes is much shorter. And of course, the benefits will need to convince both the patient, the care provider, but obviously also the governments that see the benefits. There, of course, like you mentioned, NHS or UK, where the system is, I would say, government controlled. Of course, it's easier to measure the benefits for the system in terms of spend than in a system like in the Netherlands, where it's very difficult to trace actually what is happening where and how the money flows stream. Or in Germany, the Bismarckian system is somewhat more difficult to trace in that respect. But in terms of efficiency or speed or benefits for patients, there I think there's an opportunity to accelerate.
What we learned, so we do a lot of, we want to measure the impact of technology, but we learned that it will never change the mindset of people. It's relevant to make policy decisions, to make the good decision, but it doesn't change the heart and minds of people.
Okay.
And there you need stories. You need stories about, like you said, this patient with this rare disease, that there's no treatment, but if we work together, we can find information, there's treatment for me. So this personal health care, that's a dream. And you have a dream of time care, like you said, I want to have this asset now. Yeah. So these are really important, we call that narratives, we call that, that dreams, and they're strong around healthcare. We did a study with like 5 strong dreams that we need to express on and on, that this is what was happening. But also we interviewed you all, and we started to, and what we saw that you had personal dreams. You had personal dreams for someone in your neighborhood or someone you know, that if you would make a difference. And that personal dreams linked to that grand narratives, that grand promises of big data, that is changing the mindset. So we studied that, Martha Stevens did a study on that, beautiful work, but to change the mindset, you need grand visions connected to personal dreams.
That's amazing. But
you need also a functioning example. You have to say,
of course,
dream is not enough. You have to say, okay, someone has to transform the dream into an app or whatever.
No, it was about the heart and the mind. You have the heart and the mind, then you need something else.
So you have to start with a dream, but someone has then programmed the app. Someone has then to test and show the benefit of the app. And then you have to convince the health insurance company or someone to pay for it. So I think this kind of start with a dream and you end up to convince the health insurance company that this is useful to spend money for it.
And this links back to what you had mentioned about the press. How do we get the press, that mindset? I mean, really around.
To tell you a story, in all projects I collaborate with, I said, okay, I don't want to control communication of the project, but I need to be asked where you are preparing a pre-release. Because we have to send a correct message regarding my concern, privacy. You can't never say, we will process 1 million of patient data. You have to say, we will process with security patient of data. It's not the same. Patient data is not the same. You have to communicate to the public in a correct way to provide them information, and security. This is from privacy perspective. For me, communication is really relevant. 10 years ago, a very large, big national data project in Spain, in Catalonia, failed due to a bad communication.
Wow, right.
Because everybody thought that Big Brother were coming, that healthcare public system will send data for insurance companies, and so on. All were really false. It was a fake news. But they haven't communicated in the adequate way. Communication is really relevant in that.
So, Europe is a hothouse of innovation. I mean, if you talk about just the amount of technology that's going on and the patents and what we're doing. That being said, what can we learn from other countries around the world that we can apply to this? So it's a completely out of sight. What can we steal from China? What can we steal from the US? What can we steal from Latin America, Japan? Any ideas when it comes to BigMedilytics?
Yeah, you could start. In my area, usually jurist thinking is functional thinking.
You say that one more time.
In my area, the legal teams provide solutions.
Okay.
They are compulsory obliged to do that.
Yeah.
The legal thinking is not about theory. It's okay. They have a really theoretical corpus of knowledge, but they try, in any case, to promote solutions to solve problems. And they have to work really hard with the company, with the researchers, with the developers, and so on. Here, sometimes I perceive the work of legal teams is a certain desk or office work, absolutely disconnected from reality and thinking only on how to apply a certain theory of law. Then, for me, the most important lesson learned during my studies for my field doctorate thesis was, okay, if you are reading an American jurist, he will provide usually a solution. And I think this is really relevant.
Wow.
Because we work for you.
Very specific example.
No, I also would say what we need, what we can learn is a little bit enthusiasm and positivity, that we find a solution. Yeah. So in Europe, sometimes, at least in Germany, sometimes people are finding 100 ways why it's not possible to do it.
Yeah, you're right.
And then the GDPR is always number one why it's not possible. So we need to find solutions, and we should be more a little bit optimistic that we find solutions, and we have this kind of dynamic which Americans or Chinese have. They start away and run. Maybe sometimes you think they run into the wrong direction, but let them run. Yeah, but they are optimistic and have dynamics, and I think this is a little bit what we need as well: optimism and dynamics.
So I went to the United States because I had the same question. I went there for a year, and I worked at Kaiser Permanente because they work with big data. So I want to understand, how do they do that?
Sure.
And one of the lessons I learned, that in Europe we always have different values we take into account. So we have efficiency, patient satisfaction, provider satisfaction, the public good, and based on that we come to a compromise. At Kaiser Permanente they had one goal: to make the healthcare efficient, and they're willing to take everything on that role, and that was so impressive. So they take all the effort, and we are not ready to go for one goal. We always go for multiple goals. So that's also what I learned.
Interesting.
So if we keep all the values in the basket, it will be different. So we can learn from the United States to focus.
Yeah, focusing is good. I think this is also, so we just had a discussion with our BigMedilytics project. We discussed with health insurance companies, and basically we made a calculation that we save 400 euros per patient. Yeah. And you would invest 50 euros. So it's what would be okay, I would say. But then always, is this model correct? Is it really right? Is 400 euros enough for savings? And is it enough patients? Or do we need more patients? Is it too small, too big, or whatever? So all of a sudden, again, we kind of have our cut in our head or so and want to focus on many other different issues. And maybe just take the 400 euros with a few patients. It's better than nothing. Yeah?
Right.
I have maybe a little bit of a different view here. I think there's a lot in Europe that we can leverage. So Europe has a rich spectrum of countries and different healthcare systems and ways of working. And there's, I think, in many places pockets of excellence. So if you look at, I don't know, Denmark, South Denmark, where data are freely, well, readily available and can be deployed, for instance. And there's other examples as well. So I do think that in Europe, if we are looking for areas where we have the best solutions, leverage. So we're, of course, all the time complaining about the fragmentation of Europe. But in the fragmentation, there's also richness. And if we are able to identify that, adopt it, learn from it. By the way, even, sorry, maybe you don't agree, even the GDPR, I think, has a lot of very positive aspects because it takes the privacy of the person. It is, in principle, is a very good way to ensure and embed trust in people, in patients, in us. Now, it's unfortunate that every country and region interprets these rules differently. But in principle, I think it's a very good point that we have. So I do think, and of course elsewhere there's also good things, but in Europe there's also a lot of good things that we can deploy. And we have the tendency to look far away because then everything is better. And by the way, I do agree with the Kaiser Permanente example, but of course they are both the healthcare provider and the insurer, and they are looking to optimize basically their business, if you like, which is good, and maybe we should do the same. But so that's a good example. But in Europe, we also have good examples.
And we are all but naive.
Let me tell you one thing. I completely agree with your approach to GDPR. This is not the problem.
No.
GDPR is a good rule. You have to remember that during the process of GDPR, the European Association of Rectors wrote to the Commission saying that in the version of 2012, it will be impossible to research on healthcare area.
Yeah.
And they changed their mind, they changed their approach, and GDPR is really an interesting tool.
Yeah.
But how the data protection authorities or different countries are applying in practice GDPR, this is the problem.
That's the problem. Yeah, fully agree.
That's the reason I mean that, okay, we should look for functional, practical solutions. And it is possible, but not in this way to approach to the GDPR.
No, fully agree with you.
So let me take this down on a more personal, pragmatic level, which is, it's my understanding that there were close to 300 people involved in the whole BigMedilytics across the 12 pilots, also an organization. And I know some of those people, and I know this is really on top of their normal activities, right? This is not necessarily planned in. They didn't have a job to do BigMedilytics. It was like, hey, BigMedilytics is here. This is an opportunity, let's do it. So there's this sense of people, you know, having conflicting priorities in order to do this optimization. How did you manage? Or do you suggest we need to change that mindset? Do we need to free up space on the ecosystem for them to do this? Or other examples, I don't know, I just threw that out. I could be wrong. Is that too challenging for you?
No, I think in general, first of all, of course, we got money from the Commission to do it, so it kind of was a trade-off, and I think we all agreed that I think this was a great project. It was and the main issue or the win situation for us, it was to work with great people and to learn something. Yeah. So this, I think, was the reason which kept us all, or our team, heavily involved in it. It was fun. It was we created something. It worked, and it was fun to work to different people, having workshops or whatever, having a different perspective. I think this is was fun to work with, and so from our perspective, it was a positive project, definitely.
But let me challenge you to speak or put yourself in the shoes of the other organizations who weren't a part of the program. So if we go forward, you know, the program's over, right? The funding's over there. So now it's up to us as individuals. Sorry to be challenging. I'll ask you first. How do you see that changing?
So you asked the question, should we have some free space? I think we should have free space, and especially new teams. So that's what's with this kind of project. You have a new team, you work with that, and you do something, and then you go on, and then you bring your knowledge to a new team. So this free space, I agree with you, and that needs to be possible. I don't know how, but I think that is irrelevant. And that's why I think maybe what we can learn from research, that we all can learn from innovation. And that's also, this call was not only about research, about innovation. Yeah. So this kind of projects create free space. And I wish that for many people. The other thing, and I think we have to limit that free space, because we had to do it together with our own work. And then you cannot freewheel. You know that you have to do it next day in a normal way. So that you are connected, that you are limited, that you know how it works in practice, that I think is key. Otherwise, we make things that will not work. So it has to be limited, but what we have as researchers, and in this project I was not per se a researcher, I wish that for all. And I think that is relevant. So let's find a way.
Anyone else?
I think it's always a pity with European projects. At some point they come to an end and then people go their own way. Whereas I think particularly in BigMedilytics, sometimes that's okay, I would say, because then you have done something, a company can bring it further and everything goes hopefully in the right direction, and in the end it reaches the patient. In the case of BigMedilytics, it's, I would say, a big step towards healthcare transformation. And as you said, Antoinette, it will take a long time. It's actually a pity that this consortium then will move in different directions and do their own thing. So it will be actually, and at the moment there's lots of discussion, we heard that also on the first day, about the European health data space. There was, of course, Jeroen Tas with his Gaia X. And at the moment there is the time where so much support is needed, insight is needed, and there's a lot of discussion at a very high level of abstraction with Gaia X and with the European health data space. But in the end, these are just part of the tool set I mentioned before that needs to work for the benefit of European patients and people. And there I think we have such a richness in the BigMedilytics consortium that it's a pity that that would disappear. So if there is a way to basically capture that, or at least really capture the efforts in terms of learning and to bring that forward, that I think would be a good thing.
Maybe we can start an alumni.
Yeah, that's a good idea.
Club. So and then people can join, even if you didn't join before.
Voluntarily, if needs be, or Facebook or whatever.
So a common thread throughout the 2 days, and of course, always is us as individuals, us as either patients or potential patients. What would you give as advice after these last 2 days to a EU citizen in order to help drive this? And when I say that, I would like you to imagine you have the power of every EU citizen tomorrow. What would you ask them to do to help this change?
I think that we need a proactive patient. I think we need an empowered patient, because our patients are more or less using technologies as smartphones, social networks, and different technological tools. And we need this kind of empowered citizen on. I think I don't want to say a bad word about Facebook or something else, but you need to focus what you have learned on technology in your own life to be a proactive patient and a confident patient.
Nice.
And I would take the perspective of a professional, the nurse, the physician, the technician. Yeah. And I think I would invite them to rethink their work. So give a concrete example. Now we say that working with data is bureaucratic work. But if you get the tools you have, then working with data and producing data is the key of your work. So I would invite them to rethink what their professional work, what their intelligence is, what the role of data is. That I think I would invite them to bring it further.
Nice.
Yeah, I think the empowered patient also, that the patients are asking, okay, I want to have a safe way to communicate with my doctor. I want to have a safe way to use my smartphone, to be connected, to get the data and so on. I think at least in Germany, there's a lot of things underway and more to come. And with Digital Healthcare Act to make reimbursement for digital solutions, I think is a big step forward. But at the end of the day, like medicine, we have to prove that there's a benefit. Yeah, it doesn't make sense to just sell something. Yeah, it has to have a benefit, and this is what we have to prove at the end of the day. Yeah, that there is a benefit for patients, they live longer, or that their KPIs really fulfilling, or you gain efficiency. That's also important. Yeah.
Push and take responsibility, Hans.
Yeah, so empowered patient, I think absolutely important. But I think the patient also needs to feel, I would say, almost welcome. So in many cases, so if you have the interaction between patient and care provider, and the care provider needs to put all kinds of things in a computer and is looking at the screen rather than at the patient. So it's the whole, I would say, way of working. And I think it's, by the way, I would almost say it's an obligation of us, of you, by the way, Kurt, being a member of our Philips design team, to create solutions where the patient feels comfortable, the person feels comfortable, but also the staff feels comfortable using it, where the advantages are there. I still think that we need to measure the benefits and the outcomes, but also show them to all the stakeholders, because otherwise it will not happen. It's a change, and it's a change in a sensitive area. And so I of course refer again to Jeroen Tas, who mentioned the financial market, and everybody trusts that their money is safe. But we also need to trust our healthcare data is safe. But of course, healthcare is much closer to us than a bank account and whether there's 10 or 100 euro. This is about us and our loved ones. Indeed. And so there's more that needs to be done there. And I think it's up to us to provide that security together with the healthcare professional.
We are almost out of time. I feel like we could have had this conversation for another 2 hours, not 40 minutes. Of course, this conversation is not going to end. You are going to be engaging with your networks, not only in this platform, but that the rest of the world will be engaging about this. But to give us a close before I do the formal event closing, can I ask you personally, what's the one thing that surprised you from this last 2 days?
Okay. That probably Antoinette loves me in terms of GDPR.
That is surprising,
expert. Yes, because usually I'm the most hateful part of the team.
Oh boy!
In this day, I discovered that due to the training efforts, due to the implementation of GDPR, all of the team feel concerned by these questions. And I feel that at the end of the day, I will part of the team, not the enemy, not an external person.
What surprised me is that I could follow all the technical details after 3.5 years working with you, and it's also become much more clear, the project. And I think, I learned to speak your language, and I saw it for all. So we learned a lot. So that was my main. It was easy to share things much easier than earlier in the project. So that was my surprise.
No, I think the pity or you just ask why is it a pity that we cannot continue? Yeah. And I think the pity is that we build up relationships and we know to work with each other. And I think this is really the spirit of this BigMedilytics was kind of impressive. And maybe not surprising, but at least it definitely was impressive. And also what is really was impressive that the pilots really provide, or the results were really impressive as well. So a lot of pilots had really good results and achieved something which was really which was I not expecting in the beginning. So I think this was impressive, and the team spirit was impressive as well, so that we could continue forever.
Nice. Hans?
Yeah, so the most surprising thing for me was that such a big consortium, so when we started with the initiative, actually had a number of discussions with Milan and Suprio, on the sheer size of the consortium,
Yeah.
and that such a big consortium can come up with such a homogeneous end result. And of course, well, the discussion proves that, and even I would say the legal person being really a part of the
including,
team, but so important to really make a success of this.
Thank you all very much. That was I found that rather enjoyable and enlightening. This, ladies and gentlemen, brings to the end our 2 days, and on behalf of the event organization team, not only at Philips but also our partners at Incliva Valencia, I would like to thank you all for your participation, and I might also add all the individual participants in the whole research program, the 200 to 300. I think we're also very proud of the last 2 days of what we did going forward. So let us join together across the system from private and public. Let's make this transformation happen and improve the people around the world, not only in Europe. Thank you and good night. Ciao.